Dr. Tim Conwell. Welcome to the first video program in a three-part series covering the examination of the neurological and musculoskeletal system. All too often, the clinician tends to focus in on a specific portion of the examination in his overall workup, omitting or shortchanging other sections of the evaluation, which may be beneficial in the overall workup of the patient in establishing a diagnosis. This video program series is designed to instruct the clinician on what areas require examination and how to examine these areas in order to perform a complete neurological and musculoskeletal exam. By screening anatomical regions or systems of the neurological and musculoskeletal system, the clinician is less likely to miss a significant lesion. This program, the first of a three-part series, is called Central Nervous System Evaluation. In this program, I'll cover the essential segments in completing a central nervous system exam to rule out or screen for an upper motor neuron lesion or other CNS pathology. The program covers a regional evaluation of the brain and spinal cord. A lesion of the brain or spinal cord which produces the following characteristic signs is called an upper motor neuron lesion. The characteristics of a UMNL, or upper motor neuron lesion, are spastic paralysis, hyperreflexia, that is a 3+ or greater reflex utilizing the Wechsler scale, absence of superficial reflexes, clonus, which is more than one contraction per tap, lack of atrophy, absent fasciculations, and reaction of degeneration. To perform the neurological evaluation of the central nervous system, the following anatomical structures are evaluated or screened for identification of a neurological lesion. If we evaluated the physiology and integrity of the CNS, a lesion can be screened for or ruled out. The major anatomical structures that we want to evaluate are the cerebral cortex, the cerebellum, the brainstem, and the spinal cord. There are a number of important reasons for evaluating the central nervous system. Initially, you have to ensure there are no underlying lesions that would preclude certain types of treatment, such as spinal manipulation. Secondly, in today's litigious environment, your records have to be thorough. They have to reflect proper evaluation of the CNS. And most importantly, early detection with timely referral of these types of lesions will significantly improve prognosis. It is important to recognize that patients with CNS lesions must be identified. We all know that separation of patient history from the examination is essential in proper record keeping. In fact, the evaluation begins as soon as a clinician enters the examination room. The history often dictates the extent of the neurological examination. With a clear understanding of the patient's clinical history and review of systems, the clinician is able to proceed with a more specific and directed neurological evaluation. During the history portion of your examination, in your systems review, it is important to get from the patient critical data that may indicate the presence of a neurological lesion. In the history portion of the examination, you should address questions which would dictate a specific diagnostic workup. The following symptoms that are ascertained during the review of systems indicate the need for a more thorough neurological evaluation. These would include loss of interest, drive, or energy, disorders of memory or thought process, headache, seizures or convulsive activity, loss of consciousness, visual changes, hearing loss or tinnitus, balance difficulty or vertigo, speech or language or swallowing difficulties, clumsiness, weakness, tremors, spine pain as seen in Lhermitte's sign, sensory loss, impotence, or bowel or bladder dysfunction. Now, let's go into the examining room and go over how to cover the general components of a neurological evaluation to screen for an upper motor neuron lesion or other types of CNS pathology. In performing the evaluation of the central nervous system, the clinician should evaluate the patient's mental status, speech and language functioning, cognition, evaluation of the cerebral cortex, cerebellar signs, including coordination, gait, and equilibrium, cranial nerves, and long tracts of the spinal cord, including the ascending and descending tracts. We first begin our examination with evaluation of the patient's mental status. This is generally done while taking the patient's history. The clinician should formulate impressions as to the patient's intellectual competence, as well as observing the patient's demeanor, memory, and orientation. The following are evaluated to ascertain the patient's mental status. Number 1, level of consciousness, or how alert the patient is. Number 2, appearance and behavior, or in other words, the patient's affect. Number 3, the patient's orientation. Number 4, speech and language functioning. Let's talk about the patient's level of consciousness, or how alert the patient is. The levels of consciousness include 1, alert, 2, slight drowsiness, 3, light coma, in which the patient may be briefly aroused by verbal stimuli. Next, moderately deep coma, in which the patient may be aroused for a few seconds by noxious stimuli. And deep coma, in which the most noxious stimuli will not produce an arousal. The level of consciousness is almost always alert. Any other level would suggest a cerebral cortical dysfunction and requires immediate neurological referral. However, it's wise to chart the patient's level of consciousness in your records. Next, the clinician should evaluate the patient's appearance and behavior, or the patient's affect. Evaluating the patient's affect begins during the initial introduction. The clinician should note the patient's appearance. Observe for grooming, dress, carriage, and makeup of your female patients. Poor grooming, careless dress, or indifferent posture raises questions about mental deterioration or depression. In addition to the patient's appearance, the clinician should observe the patient's demeanor. Is the patient cooperative? Are they angry? Do they show hostility? Are they evasive? Depressed? In charting the patient's affect, your record should reflect some descriptor of what the patient's affect is. Is their affect normal? Do they appear depressed? Are they angry? Is their affect flat, etc.? Next, let's talk about the patient's orientation. The patient is evaluated for orientation to time, place, and person. If the patient knows what time it is, if they know where they are, and if they know their name, they are considered oriented 3X. This is ascertained during the intake questionnaire process. If they have difficulty with any of these categories, there is a suspicion of cerebral cortical dysfunction. Normal orientation is charted by stating the patient is, quote, oriented 3X. Now let's pay close attention to the patient's speech and language function. During the history, the patient's speech and language functioning capabilities are ascertained. In order to speak, there are numerous muscular and neurological structures which must work in concert, including the respiratory muscles, vocal cords, soft palate, tongue, lips, and cranial nerves. In evaluating for normal speech, you must be able to recognize difficulty in pronunciation. This is done by checking lip movements by asking the patient to say, me, 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 or by evaluating tongue movements by asking the patient to say, la, 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 or palatal movements by asking the patient to say, ga, 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 ga. Generally, speech is evaluated by just listening to the patient and their pronunciation. If they have difficulty pronouncing their words, if they slur their words, then we are dealing with a problem with speech. Next, we should evaluate the patient's language. As opposed to speech dysfunction, language impairment is the inability to use abstract language, which implies cortical dysfunction, or a problem with the cerebral cortex. If a patient has difficulty with language, he is considered aphasic, which is described as Difficulty in expressing oneself in speaking or written terms. This is easily ascertained during the history portion of the examination. Difficulty with aphasia suggests a cortical dysfunction of the dominant hemisphere and requires neurological consultation. Essentially, in evaluating your patients for speech and language difficulties, you are looking for the patient's ability to pronounce their words correctly and to respond appropriately to your questions. This is done very simply during the history portion of the examination. Now let's briefly review how to chart the patient's mental status. This is done by stating, the patient's mental status shows the patient to be an alert, pleasant, cooperative female or male who is well-oriented 3X. The patient's speech and language function is normal. The patient's affect appears normal. After the observational evaluation for mental status, we want to evaluate the patient's cognition, which in essence is the patient's ability to think clearly and concisely. Cognition is evaluated during the history taking of the evaluation as well. You need to think about whether the patient is able to present a clear and logical history of the events of an injury, accident, or illness. Are they able to perceive, recognize, judge, reason, sense, and or imagine? Cognition is generally broken down into 4 categories. The first is general information. Next, memory. Third, attention and concentration. And last, abstract reasoning. The patient's general information can be perceived from their ability to fill out the doctor's intake questionnaire and their ability to communicate to the doctor about recent events. Next, we want to check the patient's memory. Memory is divided into holding function, current memory, and remote memory. This is evaluated by ascertaining if the patient's able to remember current events, events of the recent and remote past, and formulate other thoughts in a concise and logical manner. Next, let's talk about attention and concentration. Inability to concentrate or lack of attention suggests an impairment of the dominant parietal lobe. Attention and concentration are evaluated in numerous ways. One way is to have the patient repeat digits forwards and backwards as given by the clinician. Another method is to have the patient subtract by 7 from 100. Poor performance in subtraction or repeating of digits suggests an organic brain disease or possible mental retardation and requires a referral to a neurologist. This finding is particularly acute in patients with closed head injuries and can be readily seen in patients that have been involved in motor vehicle accidents. And lastly, let's talk about abstract reasoning. Abstract reasoning is the ability of a patient to interpret the meaning of a commonly understood proverb such as, "A stitch in time saves 9, don't count your chickens before they're hatched, the proof of the pudding is in the eating, a rolling stone gathers no moss." Now let's think about cognition for a second. Generally, the clinician only evaluates the patient's ability to recall the history of the events of an injury, accident, or illness, and identifies difficulty with short or long-term memory. If there is a suspicion of difficulties with history or short or long-term memory, it's best to have a neurological consult performed. Although it may be informative to evaluate the patient for dysfunction with attention, concentration, and abstract reasoning, it is not routinely performed because of the ability to ascertain the patient's cognitive processes from the patient's response to questions during history. That is to say, evaluation of the general information and of the patient's memory during the history portion of the examination. Now let's put the cognition portion of the examination into perspective. I've given you tools that are generally used in a neurologist's office. In our offices, what we're looking for is the patient's ability to give you general facts about himself and the patient's memory. Can they give you the facts of an injury or an accident? Can they tell you about their symptoms? Can they articulate the issues to you? That's what you're looking for. So in essence, with cognition, can the patient communicate with you? Do they think properly? Can they remember events? That's what you're looking for. That's done very simply during the history portion of the examination. The rest of the fine-tuning in evaluating the patient's cognition can be left to the neurologist if you perceive a general problem with general facts and memory from your patient. The next major section of the CNS evaluation is evaluating for problems with cerebral cortical dysfunction. To evaluate the cerebral cortex, observe the patient for signs of aphasia, agnosia, or apraxia. Aphasia is the inability to communicate through spoken or written language due to a cortical lesion rather than by mental defect, disturbance in the sense organs, or paralysis of the speech muscles. In simple terms, if the patient is unable to understand you when you speak to them or speak to you in a coherent fashion, they are considered aphasic. Aphasia is routinely evaluated during the history. Can the patient understand your questions and can they respond appropriately? Evaluating for aphasia is done during the speech and language functioning portion of the examination. Now let's talk about agnosia. A patient with agnosia is unable to recognize objects through the 5 special senses, that is, smell, taste, touch, sound, or sight. This is tested by the patient's ability to recognize objects such as a coin placed in the palm of the patient's hand with the eyes closed to see if they can identify it. This is called astereognosis if they're unable to recognize the coin. I generally test this by observing the patient's ability to recognize simple objects such as a button or a shoestring, which is necessary in the performance of dressing and undressing. And finally, with evaluating the cerebral cortex, we look for signs of apraxia. A patient is apraxic if they are unable to perform purposeful, skilled, or unskilled movements. Again, is the patient able to tie their shoestring? Are they able to button their shirt? These require great dexterity and skill. So if the patient's unable to dress or undress themselves, they may have problems with agnosia or apraxia. Agnosia is unable to recognize a button or buttonhole or a shoestring, so if they are unable to recognize these things, they can't take their clothes off. If they are unable to perform purposeful, skilled movements, they are apraxic. That means to say they're unable to tie their shoestrings or button their shirts. So generally what we're looking for is, can patients dress and undress in evaluating for signs of agnosia or apraxia. In charting for cerebral cortical dysfunction, if we see no signs of aphasia, agnosia, nor apraxia, the record should reflect that. I generally put in my chart that there are, quote, no blatant signs of aphasia, agnosia, nor apraxia. This is all performed strictly by observation and listening to the patient communicate with you. After we've evaluated the patient for cerebral cortical dysfunction, we now want to look for cerebellar signs. In evaluating the cerebellum, vestibular apparatus, and certain tracts of the spinal cord, the patient's coordination, gait, and equilibrium are tested. Coordination is evaluated by having the patient perform numerous tests for cerebellar signs. The patient is evaluated for signs of dysmetria, dyssynergia, dysdiadochokinesia, heel to shin test, and rebound phenomenon of Holmes. Okay, now let's go through how to evaluate the patient for cerebellar signs. Deb, would you stand for me, please? We're going to start with dysmetria, which is pass pointing. Have the patients put their feet together and reach out with their hands and do as I do. Finger to nose, please. And back out. Finger to nose. And back out. Now close your eyes and do it again. Finger to nose. This is dysmetria for pass pointing. Do this one, please. Now open up and touch your finger to my finger. And back. Now your finger to my finger and to your nose. Now back to my finger and back. Now do it with this side. Finger to nose, to finger, to back. That's dysmetria for pass pointing. Now put your hands out like so, And I want you to tap me quickly, like so. Real quick, real quick. This is dyssynergia for rapid repetitive movements. A patient with a lesion of the cerebellum will be discoordinated and won't be able to tap equally. So tap for me real quick. See how smooth and rhythmic that is? That's dyssynergia. Okay, now I want you to take your hands and go back and forth rapidly. This is rapid alternating movements, or dysdiadochokinesia. A person that has a cerebellar lesion will not be able to do it smoothly and uniformly. Now, once you put your hand on my shoulder and watch my foot now. I want you to run your heel, use this for balance. Run your heel down your shin. The right one, right. Now do the left one, down the shin. Now we're looking for smooth movements. If they're unable to do that and it's jerky, we're having troubles with the cerebellum or a cerebellar lesion. And last, we'll do rebound phenomenon of Holmes, which is have the patient make a fist. Now pull your fist towards your shoulder, okay? And then let go. Do it again, and then let go. If they slap themselves, there's a problem with the cerebellum or a cerebellar lesion, and that's the rebound phenomenon of Holmes. So let's review that one more time. Let's do finger to nose, like so. Finger to finger, finger to nose, back to finger. You're doing great. Over there, now let's do this one, finger to nose, finger to finger, and back out. Out here, rapid repetitive movements, back and forth, rapid alternating movements. Good, thanks. Have a seat. We have just reviewed the screening procedures for evaluating a patient for a cerebellar sign or coordination difficulties. We looked at the patient's ability to do finger to finger and finger to nose, rapid repetitive movements, and rapid alternating movements. In performing those three coordination tests, dysmetria, dyssynergia, dysdiadochokinesia, we have essentially screened for a lesion within the cerebellum. Now let's chart to make sure we get in our records that we did evaluate the patient for problems with coordination. So the chart should reflect that there were no signs of dyssynergia, dysmetria, nor dysdiadochokinesia, and heel to shin test was performed well. Now that we've evaluated patients for coordination, let's look at their gait. Gait provides information about the patient's proprioception, strength, and body symmetry. Gait is evaluated by asking the patient to walk across the room or preferably down a hall with the patient turning and walking back. The clinician should observe for posture, balance, arm swing, and movements of the leg. Normal gait is easily observed. Patients who demonstrate abnormal gait are considered ataxic. Ataxia is the inability to coordinate muscle activity and is observed in patients with abnormal gaits. Now let's talk about more classic ataxic gaits. First, let's talk about the steppage gait. In this ataxic gait, the patient lifts their knees high and then brings them down with a slap of the foot on the floor with a forward step. This suggests a lesion of the L4 nerve root or peroneal nerve. Let me demonstrate it for you. If I have an L4 radiculopathy or a lesion of the right peroneal nerve, as I walk out, my nerve is not strong enough to get the extensor muscles of the ankle to come up, and so therefore my foot drops. So it looks something like this. Normal, slap, normal, slap. It's called a foot drop gait. And last, let's talk about the limping gait. Limping gait is demonstrated with the patient putting the affected leg or limb down carefully, taking short steps, quickly removing the weight from the painful limb. This suggests a musculoskeletal lesion of the back, sacroiliac, hip, knee, or ankle joint. You will readily recognize this gait and often see it in your practice. This type of gait indicates a musculoskeletal lesion and needs to be charted. Let's see what it would look like. If I have a lesion of the right hip or right sacroiliac, I'm going to take and put my weight on my good leg, and as I put the weight on the bad leg, I'm going to come off of it real quick. And so I'm going to come off of it real quick and put the weight back on the good leg. In charting for ataxia or abnormal gaits, if there is normal gait, the record should reflect that there were no signs of ataxia. If there are abnormal gaits, a description of the type of gait observed should be documented in the record. For cerebellar signs, we've covered coordination, gait, and now let's look at equilibrium. Lesions of the cerebellum, vestibular apparatus, or posterior columns may manifest themselves with disequilibrium or difficulties with balance. Evaluation for equilibrium is done by testing the patient for Romberg and tandem gait. Okay, let's evaluate Deb with Romberg test. Would you stand up for me, please? Put your feet together and hands out like so. Now we're looking for any imbalance problem. See how she's able to stand there very steady, no movements of the hands, no swing of the body. This is the first part of Romberg. Now will you take your head back and look at the ceiling for me? See how she's still steady? That's the second part of Romberg. Now close your eyes for me. That's the third part of Romberg. Now I'm going to tap. Very good. Okay, now let's go back and review the three parts of the Romberg test and what they mean. So Deb, put your hands out like this. Now with the feet together and the hands out, if she sways back and forth, or in extreme cases she may fall, just like a sack of potatoes, that indicates a lesion within the cerebellum. Now, Deb, will you take your head back and look at the ceiling? Now if she starts to get dizzy or sway, that means we may have a lesion of the vestibular apparatus. And now, Deb, close your eyes for me. Now, with her eyes being closed, I'm going to tap her to see if she holds her steady position, which she did. And with her eyes closed, that's looking for a lesion within the posterior columns, because when we have her close her eyes, we take away her sense of position, and with that, therefore, we're checking proprioception. All right, now let's talk about how we would do it in our office. Deb, would you put your feet together, please? Now put your hands out like so. Now move your head back, look at the ceiling. Now close your eyes. Now I'm going to come in and tap. Good, thank you. That's the Romberg test. And as you noted, she was steady and had normal balance throughout. A note of caution. When you're performing the Romberg test on your patients, a true positive Romberg is where the patient may fall like a sack of potatoes when you have them put their arms out. So if you perform the test with the patient standing next to your examining table or next to a counter, when they fall, they could severely injure themselves. So put them in a place in your examining room where they are away from objects in case the patient has a true significant cerebellar lesion and may injure themselves as they go down. So be in a position where you can grab them if they start to fall. The second part of the equilibrium examination is tandem gait. Tandem gait is a very sensitive test for balance. It's performed by asking the patient to walk heel to toe in a straight line. The patient should be able to proceed without side steps or loss of balance. This test is present in patients with a lesion of the cerebellum and may be present in drug and alcohol abuse patients. Now let's review how to do this test. Deb, would you stand over here for me, please, and walk towards me heel to toe. Oh, you made that look easy. You saw Deb perform tandem gait in a normal fashion. If the patient's having trouble with tandem gait, this is what you will see. They will start off and they'll have difficulty putting that foot there and they'll go off to the side. And you've readily seen this on TV when they're checking for drunk drivers, which is in essence a lesion of the cerebellum from alcohol abuse. Now, in charting for equilibrium, if the patient has a normal tandem gait and normal Romberg, the chart should say something like, Romberg is negative, tandem gait is performed well. The next major section in evaluating the central nervous system are the cranial nerves. As you are aware, there are 12 pairs of cranial nerves which originate in the brainstem and provide motor and sensory innervation for the head and neck. By evaluating the cranial nerves, the clinician is able to assess the neurological integrity of the brainstem as well as the cranial nerves themselves. The 12 cranial nerves are CN, or cranial nerve 1, the olfactory, which is for sense of smell. CN2, the optic nerve, which is for visual acuity. CN3, oculomotor, which is for eye movement, pupil constriction, and eyelid elevation. CN4, trochlear, which innervates the superior oblique muscle, which produces eye movement down and inward. CN5, the trigeminal nerve, which supplies motor to the muscles of mastication, including the masseter muscle, temporalis muscle, medial and lateral pterygoids, and sensory for sensation to the face of the first ophthalmic division, second maxillary division, and third mandibular division. CN6, the abducens nerve, which innervates the lateral rectus, which produces eye movements outward. CN7, the facial nerve, which innervates the muscles of the face for facial expression and sensation to the tongue, innervating the anterior 2/3 of the tongue. CN8, the acoustic nerve, is for hearing and balance. CN9, the glossopharyngeal nerve, provides motor for gag reflex and sensory for the posterior 1/3 of the tongue. CN10, the vagus, providing sensation to the pharynx and larynx, and motor, providing innervation to the palate, pharynx, and larynx for speech and swallowing. CN11, the spinal accessory nerve, providing motor impulses to the sternocleidomastoideus muscle and upper trapezius. And finally, CN12, the hypoglossal nerve, which provides motor impulses to the tongue. For patients without specific history of signs or symptoms suggesting a cranial nerve lesion, a screening examination of the cranial nerves 3 through 12 may be beneficial in evaluating for brainstem pathology. Screening of cranial nerves 3 through 12 can be done very quickly, providing a simple routine is followed. Let's go through this screening routine to evaluate these nerves. In evaluating cranial nerves 3 through 12, we can screen them rapidly and quickly. By evaluating these nerves, we're looking for a upper motor neuron lesion or an injury to the brainstem or higher centers, or a lower motor neuron lesion, which would be an injury to the cranial nerve itself. Let's start with doing the evaluation in groups of 3s. So we're going to evaluate cranial nerve 3, 4, and 6 at the same time. We'll start with the 6 cardinal signs of gaze, which evaluates cranial nerves 3, 4, and 6. So you have the patient follow your finger. Would you look at this, please, without moving your head, and follow it with your eyes. So we're going to come up and out, and down and in, come back to center, down and out, and up and out, and then back and lateral over here, and then back. And what you're looking for is to see that the eyes track your hand. Now let's do it one more time and talk about what we're seeing. Follow this with the eyes, please. If we go up and out, that's oculomotor 3. If we come down and in, her right eyeball is oculomotor 3. Her left eye is the superior oblique, which is the trochlear nerve. If we come up here and go down and out, her right eye is down and in, which is the superior oblique muscle, which is the trochlear nerve, and the rest of the eye movement is oculomotor 3. We're going to come up and over. These are all oculomotor 3. Down. If we go lateral, her left eye is being moved by the lateral rectus or abducens nerve, and her right eye is the medial rectus, which is oculomotor 3. Moving it over here, we're looking for the right eye, which is the lateral rectus, which is the abducens or cranial nerve 6, and the left eye is the medial rectus, which is cranial nerve 3. And then back. After we perform the 6 cardinal signs of gaze, we want to look at the pupillary reflex. This reflex is very similar to the deep tendon reflex, except we're going to use light as our sensory source, and we're going to look for pupillary constriction. In performing the pupillary reflex, you cover one eye and shine a light source into the eye, opposite eye, and see if you get a pupillary reflex. That's the normal response. The consensual reflex is the opposite eye that is not seeing the light should also constrict. And we're going to do that for both sides. Look right at me, please. Shine a light source into the eye. Look for pupillary constriction. Uncover the other eye and see if the eye then dilates, which means it was constricted from the light. That's a pupillary reflex. Second, we're going to look at the accommodation reflex by having the patient look at your finger and follow it in. Now, as the eyes converge, you should get pupillary constriction. That's known as the accommodation reflex, which includes pupillary constriction and convergence. And finally, with evaluating oculomotor 3, 4, and 6, we want to look for nystagmus. There are essentially two parts of nystagmus. The first part is a slow and fast component, which is a true nystagmus. The second part is a false nystagmus, which has a slow rhythmic component to it. Nystagmus is essentially to and fro oscillation of the eyeball when you have put it into one of the cardinal signs of gaze. So when we're doing our cardinal signs of gaze, if you would watch this for me, please, we're going to go up and we're going to see if either eye does an oscillation. Now, if it's true nystagmus, the eye will come back slow and jerk back to where it was. Come back slow and jerk back. If it's false nystagmus, the eye will slowly move back and forth. What does this tell us? A nystagmus may mean we have a injury to the central nervous system or the vestibular apparatus. When we have an injury to the vestibular apparatus with nystagmus, you always get vertigo when you're eliciting the nystagmus response. It should be noted that when evaluating for nystagmus, if you only get it with lateral gaze, this may be normal. So in summary, of ocular motor 3, 4, and 6, initially we're doing the 6 cardinal signs of gaze and looking for nystagmus. Number 2, we're looking at the pupillary reflex. And number 3, we're looking for the accommodation reflex. Let me now go through it, and you can see how it's done quickly and efficiently. Deb, would you please look at my finger for me? Now follow this with your eyes without moving your head. Up and out, down, back, across, back up, now out, hold at the end. All these you need to hold at the end looking for nystagmus. That's good. While I'm doing that, I'm looking for the pupil size. Then we do the pupillary reflex. Please look at me, shine the light in, see if the pupil constricts, look at the other side, see if it dilates, change sides, shine the light in the eye, look for pupillary constriction, open up, see if it dilates, and then the accommodation reflex, follow this in. The eyes should converge equally, and we should get the pupillary constriction. If these are all done normally, the patient has a normal cranial nerve 3, 4, and 6. The next section of the screen for cranial nerves, we want to look at 5, 7, and 8. 5 is the trigeminal nerve, and we evaluate that by looking for the sensation of the face in the ophthalmic division, which is in the temporal area, maxillary division, cheek, and mandibular division, jaw. Now we can check for light sensation in a number of ways. We can use the back of our hand and ask the patient if they feel this, and this is checking for light touch. Again, the ophthalmic division, maxillary division, and mandibular division, or we can use a cotton swab or some other source that we can check for light touch. In my office, I like to use a couple of instruments. I may use the cotton swab and pull the tip of the cotton off so I have a nice piece of cotton off the tip of the cotton swab, and I'll ask the patient with their eyes closed if they feel this. Do you feel this?
Yeah.
Do you feel this?
Yeah.
And here?
Yeah.
And how about here?
Yeah.
And here?
Yes.
And here?
Yeah.
Now, if she responds in the affirmative of all those, there is normal sensation to light touch in cranial nerve 5. There's another way of doing it that I've found has been quite helpful, and I use a troll from my daughter's bedroom. And the way I do that is I have the patient close the eyes and see if they feel this, and I walk it all the way down. Do you feel that?
Yeah.
And I walk it all the way down here. Do you feel that?
Yeah.
And you have to make sure that you use a troll with the Rocky shirt on it. If not, I don't think you'll get the proper response. Next, we're going to look for cranial nerve 7, which is the facial muscles. And essentially the way you evaluate that is when you first meet the patient, you introduce yourself, you shake their hand, and you look for a smile. Or anytime during the history with facial expressions, you're looking for, does the cheek elevate bilaterally symmetrical? Do you get an elevation of the lips symmetrical? So let's introduce ourselves to Deb. And see, she's already smiling, and we can tell that cranial nerve 7 is working well because she has symmetry of her face with that nice smile. Okay, and next we're going to evaluate for cranial nerve 8, which is for hearing and balance. Now we've checked the balance portion of this nerve when we did Romberg testing by having the patient move their head back and look at the ceiling. And we evaluate for hearing by our normal conversation if the patient is having difficulty with hearing our questions. Does the patient report any hearing problems in the history taking? And we can also do Weber and Renee testing if we choose to do so. And that's done by this. We take a 28C tuning fork, we tap it on our hand, put it in the center of the forehead, and ask the patient if they feel it in both sides, or hear it in both sides rather. Do you hear it in both sides equally? Let's do it one more time. Hear it both sides equally? And we can check for bone versus air conduction, and we do that by putting the tuning fork on the occiput and asking the patient to tell us when you don't hear that anymore.
Right now.
Do you hear this?
Yeah.
So this patient has better air conduction versus bone conduction. That's how we check for hearing. But essentially in a screen, you want to ask the patient, are you having any troubles with hearing? And if they can hear you and don't demonstrate any problems with hearing during the examination, that essentially checks for hearing. Another way that you might want to do it is ask if they can hear a watch. Do you hear that?
Yeah.
So, very quickly, we've evaluated cranial nerve 5, 7, and 8. We did 5 with light touch, preferably using the troll. We did 7 by watching the patient smile, and when you use the troll, if they smile when you pull it out, you've got 7 taken care of. And we did 8 by checking to see if they hear us when we're in our history taking, and we can use the tuning fork for Renee testing, which is bone versus air conduction, or for Weber testing, which is midline. And next we're going to evaluate cranial nerves 9, 10, and 11 together. First we'll evaluate cranial nerve 12, which is the hypoglossal nerve, and ask the patient to stick their tongue out. Stick it out way far, open up wide, stick it out. Now see how it comes out symmetrically? We're looking for, does it deviate to one side? Stick your tongue to one side. See, now that's deviation to the left, that's abnormal, it should come straight out. Now we'll look at cranial nerves 9 and 10. We do that by using an awe stick. And after the patient has stuck their tongue out, we're going to stick the awe stick in and look to see if the uvula is midline. If the uvula is midline, that's checking 9. And then we have the patient say ah, ah, and does the palate elevate symmetrically? That's 10. So providing the patient sticks their tongue out symmetrically, the uvula is in midline, and the palate elevates with ah, you've got a normal cranial nerves 9, 10, and 12. Now finally let's evaluate cranial nerve 11, which is the accessory nerve which sends innervation to the sternocleidomastoid muscle and the upper trapezius. If we have the patient rotate the head to the left and we resist them, that's checking the strength and the innervation of the left sternocleidomastoid muscle, which sits in this region and rotates the head to the left. We also have the patient raise the shoulder, hold the shoulder up against resistance, which checks the innervation of the upper trapezius, and by doing those 2 maneuvers, we've evaluated the accessory nerve on the left side, and we would do the same on the right side. Resist for me, elevate your shoulder, hold, resist, and by doing those maneuvers, we've checked the right and left accessory nerve. But this can be done as simply and in a more efficient way during your range of motion study, which we cover in the neuromusculoskeletal portion of this video series. Since one of the points of this video is not just to show you how to do things, but to show you how to do screening tests in a quick and efficient manner, let me go through the cranial nerves and show you how rapidly this can be done. So let's do cranial nerve 3, 4, and 6. Please follow my finger. We're going to go out. And now follow it in, please. Very good. Let's check the pupillary reflex. Look right at my nose. That's it. Look at my ugly nose. See a smile? I just checked cranial nerve 7. Look right at my nose now. Pupil constriction, pupil dilatation. Look right at my nose. Pupil constriction, pupil dilatation. Very good. Now, let's check for sensory for 5. Close your eyes, please. Do you feel this?
Yep.
Do you feel this?
Yep.
Now, if you don't have a troll, you can use the back of your fingers. Okay? Now, do you hear this?
Yep.
Rub the fingers. How about this? Do you hear this?
Yep.
And do you hear this?
Yep.
Thank you. Deb, stick your tongue out at me. Okay, open up. Uvula is the midline. Say ah.
Ah.
Very good. I'll do the accessory evaluation when evaluating range of motion of the cervical spine. What we just completed was evaluating for a upper or lower motor neuron lesion of cranial nerves 3, 4, 6, 5, 7, 8, 10, 9, and 12. The last major section in the evaluation for a central nervous system lesion is evaluating the spinal cord. Evaluation of the integrity of the spinal cord requires evaluating the descending spinal tracts or motor pathways and the ascending spinal tracts or sensory pathways. There are essentially 2 descending tracts which a clinician should be familiar with. The first is the cortical spinal or pyramidal tract, and the second is the extrapyramidal. Lesions of either of these 2 tracts produce an upper motor neuron lesion and present with the signs discussed previously in this tape. Let's talk about how to evaluate the cortical spinal tract. This is done by performing the pathological reflexes. First, the Babinski reflex or the plantar stimulation reflex, and secondly, the Hoffman reflex. The way we evaluate for the Babinski reflex is by taking our Taylor hammer or a blunt instrument, raising the leg, and stroking the heel of the foot towards the ball of the foot in a circular fashion. Let's do it one more time. We start at the heel, along the lateral foot, stroking towards the center of the foot, ball of foot. And you see how the toes curl? That means the toes are down going to plantar stimulation, which is a normal reflex. Let's do the other side. Start with the heel, push hard across the lateral and towards the ball of the foot. You see the toes curl? That's a normal Babinski reflex. The abnormal plantar stimulation reflex or Babinski reflex would be extensor of the hallucis longus and fanning of the other toes. So the extensor muscle would contract, bringing up the big toe. The second pathological reflex that is checked for evaluating for a pyramidal tract lesion is the Hoffman. Hoffman is checked by flicking the middle finger of the hand with your thumb and looking for a pincer activity of the thumb and index finger. If the thumb and index finger twitch together, that's an abnormal response and indicates a pyramidal tract lesion primarily isolated in the cervical spine area. Let's do it one more time. Just flick the middle finger, and as you can see, there's no activity here of the thumb and the index finger. If they come together, that's an abnormal finding indicating a pyramidal tract lesion within the cervical spine. Now let's look at the ascending tracts of the spinal cord. There are primarily 2 ascending or sensory tracts which the clinician should be familiar with. These tracts include the spinothalamic tract, which includes the lateral and ventral portion, and the posterior columns. In evaluating the lateral spinothalamic tract, we're looking for sensations of pain and temperature. Pain is evaluated by pricking the patient with a pin and seeing if it hurts. So we're going to check this patient for pain. Do you feel that?
Yeah.
Feels good and sharp?
Yeah.
You don't like that?
I don't like it.
Okay. Or we could check by checking the patient's a response to hot or cold, where we'd put hot water or cold water in a test tube and apply it to the patient's skin and see if they felt it. The ventral spinothalamic tract carries the sensation of light touch. Again, light touch can be performed by rubbing the back of the fingers across the hand, asking the patient if they feel it.
Yeah.
We should never use the palmar surface of the hands because we'll stroke too strongly. Or we can use our friendly troll and stroke to see if the patient feels this. Do you feel this?
Yeah.
As we discussed earlier, other ways of checking for light touch is by taking the tip of a cotton swab and checking for light touch in that manner, or using a ball of cotton, pulling it off. So we've got some cotton fibers, checking for light touch this way. So we are checking for sensation of light touch or transmission of this light touch through the ventral spinothalamic tract. The other ascending tract we want to evaluate is the posterior columns. The posterior columns are the fasciculus gracilis and fasciculus cuneatus. The posterior columns transmit the sensations of vibration, deep pressure, position sense, two-point discrimination, and warm and cool. Let's talk about proprioception or position sense. In evaluating for position sense, we can start with the foot. We put our fingers on the side of the joints instead of on the top. And we ask the patient to close their eyes and tell us where the toe is in space. Now I'm going to move the toe down and ask the patient to say, where is this toe in space?
Down.
Down. Now I'm going to move it again and see what they say. Now let's look at vibration. Vibration is carried in the posterior columns, and we check vibration. We use a 128C vibration tuning fork. We ask the patient to lie down, face up with your head here and your feet down here. And we essentially check three areas. We check the medial malleolus, the ASIS, and the clavicle. Now I start with the medial malleolus and ask the patient to close their eyes and, do you feel this? Let's do it on the other side. Do you feel this?
Yeah.
Now if they feel this, you don't need to go to the ASIS or the clavicle because we've checked the projection all the way up the spine. If they cannot feel it over the over the medial malleolus, we're going to check it over the ASIS or anterior superior iliac spine. Do you feel this?
Yeah.
And you feel this. Yeah. And let's do the clavicle. Feel this?
Yep.
And here.
Yep.
Now what we've checked, would you say that for me please, Deb, is vibration or projection of vibration through the posterior columns. Now I want to check two-point discrimination. In two-point discrimination, we're determining how far or how close a patient can feel two objects placed on the skin at the same time. So we're going to turn the palm up, and I'm going to place this on your palm, and you tell me if you feel 1 or 2 points being placed on you. All right? Close your eyes, please. Now, tell me, Deb, do you feel 1 or 2?
1.
Now, see, I'm doing 1 first to make sure I've got the patient give me a proper response. Now we're going to try 2 and see what happens. Feel that?
Yeah.
1 or 2?
2.
And I'm going to keep going closer. Do you feel that?
Yeah.
1 or 2?
1.
1. Now, I've got 2 on her hand. I'm going to measure that and see if it's within normal limits or not. We have covered a lot of steps in evaluating the descending and ascending tracts of the spinal cord. A quick screening procedure would be to perform Babinski or plantar stimulation, and also pinprick for lateral spinothalamic tract and light touch for ventral spinothalamic tract. If you choose to do the other neurological testing, it would be indicated in your history portion. But to screen, I think all you need to do is perform plantar stimulation and light touch and pinprick. This concludes the demonstration of how to perform a neurological evaluation of the central nervous system. Remember, it's important to ask the proper questions and proceed with the appropriate detailed neurological evaluation in order to screen for or rule out a lesion of the central nervous system. Because of today's litigious environment, screening for central nervous system lesions and documenting your findings in your records is vital for risk management. Even more importantly, the necessity to screen your patients for central nervous system lesions is critical in proper patient workup prior to instituting your treatment. You could have disastrous results if such lesions are missed. I'm confident that once you have performed the CNS screening evaluation, you will become very proficient and be able to perform this evaluation not only thoroughly, but quickly as well. Thank you very much.